You are listening to the Nottingham Recovery Network podcast, where we tell true stories of people who've walked the path of recovery and hear from those that supported them every step of the way. Real people, real recovery, real hope.
Okay, welcome to this edition of the Nottingham Recovery Network podcast. Today I'm joined by Jess Rowe, team leader of RSDATT.
Hi. Not my natural environment, but here we are.
So let's get straight into it. What is RSDATT?
So RSDATT, whether you've heard of us, whether you haven't, there's lots of different pronunciations of our acronym. So we are the Rough Sleepers Drug and Alcohol Treatment Team for Nottingham City, in a nutshell.
Why was RSDATT formed? What led to RSDATT coming about?
So the government asked Dame Carol Black to do a research project onto the substance misuse services throughout the whole country. A few questions. Why is it not working? I think being the predominant one. Why are there still growing numbers of people in treatment, not in treatment? What are we missing? So I think off the back of that, it was quite evident that lack of funding, lack of staffing for one, and missing the whole cohort of the rough sleepers, and why are they not engaging?
And RSDATT's a fairly new team, isn't it? It's been around, 2 years now?
Yep, so about to hit, I think, officially the 2-year mark around Christmas time. So we were funded by the Department of Levelling Up, so it's supplementary money that's separate to the core money that government give to drug teams throughout the countries. So we were initially a pilot of, I believe, 10 different cities in the country. And I think that 2 years in, there's now 50 different cities that have been provided funding off the back of what the initial cities' evidence worked well, I suppose.
So you mentioned it's rough sleeper, drug and alcohol. Who is it that we work with?
So when we talk about rough sleepers and homeless, there's quite a few different categories. So for us particularly, it is those that are actively sleeping out on the streets. We also work very closely with the hostels of Nottingham City and those that are in housing situations that are looking quite precarious. They've been given notices of evictions. So we'll try and work as closely as we can, but we predominantly work with those that are actively out on the streets day and night.
And what are some of the sort of problems facing those people that come into the RSDATT team?
Okay, so when we are looking at kind of the people that we're looking at for treatment, so it's those that are using substances that are having a detrimental effect on their day-to-day life. So we're looking predominantly at working with those that are using heroin, crack cocaine, so things like Mamba, people might have heard of it as spice, so the novel psychoactive substances. But that isn't where we stop. So we will work with anybody that is wanting treatment for substance use, so alcohol, powder cocaine.
The full gambit, I guess, isn't it? It's anyone with substance use.
No, absolutely. So I think there's always going to be that stigma of those that are homeless are using heroin and crack. And I think that over the last 2 years, while they are predominantly the substances that we see, we have worked with amphetamine, cannabis, powder cocaine. So literally anybody that is in that situation that needs support getting into mainstream services.
And RSDATT, being a new team and coming off the back of that Carol Black report and that new funding, it feels a little bit different to some of the other teams within NRN. How does RSDATT differ from other teams?
So the main aim for RSDATT is that we go out and about. We're not boundaried by a building. Yes, we're based here. It's nice. So we've got lots of colleagues around us that are in, I suppose we'll call them the mainstream services that have always pre-existed, that we are looking at those that we know are about. They may have historically been in treatment, but struggle to come through that front door for set appointments, set times. Their lives are chaotic enough that being told 11 a.m. on a Monday morning, a lot of the people that we work with don't necessarily know it's even Monday morning, let alone 11 a.m. So we will go out and about as soon as we get into work. We're looking for people that we know that rough sleep throughout the city centre and into the wider areas of Nottingham. So we're going out to Bulwell, out to Clifton. So it's not just city centre based. And it's taking services to those individuals that have always struggled to engage with mainstream services. So we can utilise the non-medical prescribers. We can take out the health bus and prescribe in a car park or wherever those people are locating themselves. So they're not necessarily having to come to a place at a time.
So I guess a big part of it is removing barriers to treatment.
No, absolutely. And I don't think we have any barriers to our treatment anymore, which is amazing. And a lot of the feedback we've had from service users are that, I wouldn't have walked through that front door for one thing or another. It could have been previous negative experiences, not wanting to come into the city centre because it's where they're triggered for their drug use, or they've got historic issues with other service users or people, or the police can often be moving people out of the area because of begging and wanting to tidy up the city. I use that phrase very, very loosely. That we don't view it as that. We're trying to work with all these professionals to change the stigma. I think that's probably one of our big jobs is, yes, we're engaging service users to engage in treatment, but we're also breaking down stigma and barriers of other professional services, like the police, who, yes, they've got their jobs and they're trying to stop people being nuisances on the street, but actually they can work closely with us to understand the trauma that people are going through and have experienced, and explaining why they're in that situation.
Yeah, you talk about stigma there a little bit. What are some of the issues facing the homeless community in Nottingham City at the minute?
Well, I think you just have to watch TV programmes where any drug user or homeless person is represented by somebody who is asleep on the street. They look unkempt, untidy, and they tend to be showing them off as very intoxicated. So I think that is the stigma that is in people's minds, and they'll use derogatory phrases, which we don't refer to people as such. No, let's try and flip that. Let's try and educate people of the aspects that we're coming from, of being very trauma informed, of what have these people been through, and then the repeated trauma that people living on the streets will just view as their everyday to day, but sleeping on the streets is trauma that's embedded in that individual that they just view as their day-to-day life. And I think it's that assumption that you give somebody money, they will go and use it on drugs. Not necessarily. They're going to use it for food, to access some of the local homeless day centres have started putting a price on food because everyone is struggling nowadays and people don't get as many donations anymore. So services are having to put prices on things. And yes, they're small amounts, but £1, £2 for somebody who is living day to day is still a lot. So they will still beg where they can do and ask for support and help wherever they deem to be accessing it.
And I suppose, that stigma of the homeless guy on a bench has been around for years, and people don't look past that sometimes, do they? And RSDATT seem to look past that and look at the individual.
No, you tend to see a member of our staff sat on the floor next to somebody having a chat, asking somebody who they are rather than what do you want. And I think that's what we've lost, that ability to have a conversation with an individual. I've asked many people tell me a bit about yourself, and they will give that basic, well, I'm homeless and I'm a drug user. No, that's your current situation. Who are you? And that can take somebody back a little bit and go, okay, this person might care a little bit. I think that's what we do. We show that we care. We show that we want to be there to make something better for somebody. We're not there to force anybody into anything.
And that's massive. That's really different to how services have been done in the past, I guess.
No, definitely. And I think we obviously still have our core job to do. So we will still assess people. But I think that we change the way that we assess, that we won't sit at a desk with a form and fill it in. We'll have a conversation and maybe come back to the office without them and fill it in from the conversation that we've had and go from there. Learn who that person is and how we can support them to what they're willing to work with.
Okay. And what's the process for someone coming into RSDATT? How are they referred in? Is it a self-referral, or is it a variety of things?
All of the above. So as a team, we will go out pretty much every single day to look for service users that we're already aware of, but we tend to, I think 9 times out of 10, we'll stop and speak to whoever we see to ask who they are, whether they need support, explaining who we are, take a referral from there. We work really closely with the street outreach team in Nottingham, who will be out from 4 a.m. onwards to find the rough sleepers of Nottingham. If they come across somebody new, they'll let us know and refer them in. Similar to most community services in the city, we'll accept referrals from, with pretty much minimal information as well. As long as we know roughly where we can find somebody to have a conversation, we very rarely refuse.
And it seems to be a really quick process, which again is different to a lot of other services.
No, definitely. So I think it's worth noting that the core treatment, the traditional old treatment, has come on leaps and bounds, absolutely, where in Nottingham you can walk through our front door Monday through Saturday, have an assessment there and then, and be seeing if you need it for prescribing within 5 working days. With the rough sleepers treatment team, you can be seen, assessed, prescribed, go to your chemist within probably an hour of the same day of us first meeting you. So I think that we massively break down every single barrier to treatment, that walking through a front door, sitting and engaging with an hour-long assessment, coming back for a prescribing appointment, we can do that with everybody there at that one moment.
In the 2 years RSDATT has been around, what changes have you seen? You've been in RSDATT since day one. Like, what changes in the rough sleeper community? Has it got worse, better?
I think that when we very first started, we had an idea, a very rough idea as to numbers that we could possibly engage in treatment. I think we're now 2 years down the line, and I think we've currently got nearly 200 active service users open to the rough sleepers treatment team. So I think that pretty much blew us out the water of, okay, there's a lot more people here. There's a lot of the hidden homeless. In terms of changes to the community, things have got worse. Access to housing has got worse. And us trying to engage service users with an expectation that we have access to housing, which unfortunately very few services do, and what that looks like for them. I think that's what's changed. I think we're seeing quite a few new young people coming through in little dribs and drabs and cohorts. You tend to find that we get movement from other cities to Nottingham because the word spreads that Nottingham's pretty accessible for treatment. I don't think it's a secret that other services throughout the country can be waiting 2-3 weeks for an assessment, for prescribing, and somebody that's desperate and wants treatment to better their lives are just struggling as they can't manage that time. I think drug trends are changing. We're seeing a lot of lab-made medications that are overtaking that old mainstream heroin and crack. Nottingham, I've worked in the city for 12 years and it's never changed much. Money always stays the same, amounts always stay the same, but we're seeing drugs are changing, whether that's because other countries are having more restrictions put on their ability to grow poppies. The government are tightening up on imports, exports, those kinds of things, and being more wary as to how they're getting into the country, that people are making substances wherever they can now, and we can't keep up with what people are taking and what effect that is having.
Yeah, and that's a nationwide problem or an issue, isn't it? You know, we don't know what people are taking. Definitely,
and I think it's possibly copying trends that we've seen for the last 20 years in America and Canada, that they've always been a tablet opiate-based country, and that we've always thought that won't happen to us because we've had easy, accessible transport links, I'm assuming, from Afghanistan and places like that, which have now broken down completely. So dealers, people who are making these substances are catching on to, look at what's happening in America and the huge market that exists, and right, let's try it with England. And the drug users have no choice but to use substances to try and get what it is that they're after.
I guess it's a case of the substances may be changing, but the issues around the substances kind of feel similar, but treatment's got to adapt to that.
No, definitely. We've got to think on our feet at times and move with as many trends as we can and adapt treatment as much as we can. I think in terms of treatment, that has never changed, and I don't think will ever change in terms of what's accessible to treat somebody with. But it's, do we need to look at different dosing? Do we need to look at how quickly we start somebody on something to keep them safe? We know that prescribing to an opiate user is the number one harm reduction tool for an individual to keep them safe. Getting somebody on a prescription builds their tolerance massively to whatever they are taking in the community. So anything that we can do to keep somebody safe, we'll try and do it.
And in terms of someone's journey from day one, getting assessed, maybe going on a script, how far can people go with us?
As long as it takes. I think when we very first set up, the idea was that we would have somebody in treatment for 3 months. We'd be able to do enough work with them that they could then engage with mainstream services, and we transfer them to those teams where, like I said earlier, it's kind of that traditional treatment, appointment-based, time-based, area-based. Think that within the first 3 months of RSDATT starting pretty much got disproved in that people's lives cannot change that quickly, because people use substances because of their trauma, because of their situations. Housing, accessing therapies take a lot longer than 3 months. So we will try and support somebody to add some stability anywhere we can with not needing to use substances to function throughout the day. They can have a prescription that makes just that one part of their life that little bit easier. So we will have people, and we do have people that have probably been open to our treatment team for near enough the full time that we've been going, because actually this works for them. It keeps them safe, and we will adapt to make it work for an individual, and we don't force a massive change. We'll just encourage it as much as we can.
What about the team of RSDATT? Who's in the team? What kind of people do you have working in RSDATT?
So we are a team of people with loads of different experiences from loads of different areas. We are really lucky that in our funding, we are the first team in Nottingham to have their own clinical psychologist. So her addition is incredible in that we have constant learning, constant teaching, constant access to a clinical psychologist who can help us be very trauma informed to each individual and adapt the way that we work. So we range from clinical nurse specialists, we have a social worker, we have a lot of lived experience, which I think historically it's always been a little bit, how many lived experience workers can we have, how much can people disclose to service users, but actually the positive response that we have from service users, knowing that there are people in the team that have been exactly where they are and very much understand it. They get on a lot better with knowing that the person talking to them and helping them knows exactly what struggles they go through, and they can see that there's definitely another side to it, which is incredible. We have recovery connectors, so they've done the peer mentoring program. We're the first team in Nottingham to have a recovery connector successful with a senior substance use practitioner post, which is awesome, seeing that progression, that lived experience. You don't just need to stop at being a connector, you can be wherever any of us are. We have experience from other rehabs, other areas of the country. I've worked in Nottingham. I started my work in the prisons, so I've got a bit of that criminal justice background. It's really good to have that kind of wraparound holistic approach, that we know that there's people in the team that we can go, housing, please explain it to me because I don't know. Or benefits, can you explain that to me? It's social worker invaluable in that, please explain the process of how we assess somebody for social care needs, which we see a lot in our ageing population.
Yeah. What does success look like for RSDATT?
Somebody engaging in treatment. I think success, people go, well, you've not discharged them drug-free. We ask our service users what they want to achieve. And if that's collecting their prescription every single day, awesome. They're doing it. They've made their life that little bit easier. So it's so variable. So it can be as simple as collecting their prescription. We've had a huge success in getting people off to residential rehab, which is a long-term placement, move out the city. We've had a handful that have been successful and are now based in those areas that they've gone through that process with. We've had an amazing outcome with the Housing First project, and we have quite a few people that have moved from street homeless to having their own council tenancy with support. So success is different to each person.
And why do you do it, Jess? Why are you in this line of work?
Why do I do it? Because I can see the difference that it makes. I can see just those little changes as well. And I think people get too caught up on the big changes. You can see how a prescription can just add a little bit of stability to somebody, or just having somebody to talk to and to listen to them and to understand their story. And I think seeing that journey, I know I've described that it is really different for each person, but like I say, I've worked in Nottingham in the drug team for 11 years, and you'll get people going, thank you for everything you did for me. And it's that reflecting of, I did nothing. I just sat and listened and gave you advice. It was you that did it. And seeing that progression in somebody and willing it. And I think a lot of our service users have never had somebody behind them before. They come from a background of care homes, foster placements that break down, homes with parents that are substance users, or in and out the prison system, that actually having somebody go, I believe that you can do this. It is doable. And I don't think many people hear that. So I think being that person of a bit of a cheerleader, it works sometimes.
That's nice. So Jess, thanks for all that information. What though, before you go, what is the future for RSDATT looking like?
So the future for us is hopefully that our funding's continued. Our main project, I suppose you can call it at the moment, is really building on that SMD partnership work. So when we say SMD, it's the severe and multiple disadvantaged individuals within the community, which is a massive cohort of individuals. So just for context, it's those that are experiencing homelessness, mental health, substance use, crime and domestic violence. And the research suggests that people that experience it, 3 or more of those categories, I can't remember the percentages, but I believe it's a 50% more likely to not engage in mainstream services. So what we're doing massively to break that down is to build our partnership working with the street outreach team, with Changing Futures, which are the wraparound navigator team in the Nottingham city, with some of the hostels that we work with, in how are we cohesively working to help the same cohort of people that we are all seeing. So it's building on things like a joint assessment. So one of us can assess an individual and share that amongst the other services, so that somebody isn't assessed to death and having to repeat themselves to every single service, being asked the same questions time and time again, which can be pretty traumatizing for individuals. And just making sure that as individuals we all get along and are all on the same wavelength. We're all working in the same field, doing the same job, and let's make sure that we're making it actually work rather than clashing because we're all trying to do the same thing and in a cohesive manner. And hopefully down the line, so I suppose all of those services are luckily framework led at the moment, but working closer with the day centres that are charity based and with things like the NHS and the mental health services, and making sure that we're all working as much as we can to help this SMD population.
Well, thanks, Jess. Thanks for spending a bit of time with us, and just keep doing what you're doing.
Thanks.
Thank you for listening to the Nottingham Recovery Network podcast. If you or someone you know are looking for support with their relationship with drugs and alcohol, we are here to help you. Visit www.nottinghamrecoverynetwork.com for more information.